Hi everyone, I just wanted to make some quick videos to prepare you all for the upcoming quiz. And our discussion is going to start off this quick video. We'll start just talking about um, epigastric pain, patients that present with symptoms that are suspicious for peptic ulcer disease and gastritis. And just as a reminder, we'll go through what these diseases are affected by and what they affect. So peptic ulcer disease, we'll go ahead and start there. This is often caused by a certain bacteria. Do you recall which bacteria mostly affects PUD or peptic ulcer disease? If you said H. pylori or Helicobacter pylori, you're correct. But also, in addition to H. pylori infections, some patients are faced with PUD due to excessive NSAID use or even excessive alcohol consumption as well. And this is different than gastritis, which is a inflammation of the stomach lining, though can be also caused by the same things. In addition to that, even stress can cause gastritis, a little different than PUD. And so, what is that difference? I want you to take a minute to think about the difference. Now, if you said that the difference is dependent on if there's ulcers or not, you're correct. The first one is called peptic ulcer disease that we talked about, and then the other one is gastritis. Now, gastritis, being a general inflammation of the stomach lining, can be acute or chronic, and some patients don't have any symptoms at all. Now, once the condition affects the stomach lining to a point where now it is creating ulcers in the stomach lining, you might experience more severe pain, and actually, you have a higher risk of cancer as well. This is when we will start to describe it as peptic ulcer disease. So, good job for those of you that remember that key detail. And for those of you that um, need a little bit more reinforcement, I would encourage you to look up PUD and gastritis in just a little bit more detail in preparation for the next exam. Now, additionally, um, we should talk about GERD as well. Now, GERD or gastroesophageal reflux disease, sometimes referred to as GER, um, this can also cause a burning type pain in the epigastric area, but it's due to acid reflux. So that's what the R in GERD is standing for, what it means. And so typically with GERD, you might have burning sensation in the chest, can happen after eating or even while lying down. Because of the regurgitation that patients will experience, because the lower esophageal sphincter may be dysfunctional, it's weaker and it relaxes abnormally, right? Not being patent enough to keep the stomach acids down into the stomach and backflows up to the esophagus. Well, when this happens, patients may complain of a very acidic taste in their mouth, that sensation of just that burning or stomach contents coming upward instead of down. Um, Patients may also say that they have difficulty swallowing, which we term dysphagia. Some patients with GERD even start to experience chest pain, which mimics symptoms of a heart attack, but are indeed only symptoms of GERD or that heartburn, so to speak. And it can be reversed, where patients think that they're only experiencing heartburn, but indeed they are actually having cardiac type symptoms. So, in either case, you're going to investigate and use uh, both of these diagnoses as a differential, just in case you might miss a heart attack. Now, going back to the pathophysiologic mechanisms of GERD, we talked about the lower esophageal sphincter or the LES dysfunction. But what about increased intra-abdominal pressure that occurs? What conditions can cause this extra intra-abdominal pressure? If you said things like central obesity, you're correct. Even pregnancy, which when the baby displaces all the internal and abdominal organs, this can also increase intra-abdominal pressure. Or if you have a hiatal hernia, which would cause a protrusion of some of the duodenum up into a cavity, particularly pushing up on the diaphragm, then you would also experience symptoms of GERD as well. Additionally, with the abdominal pressure and the lower esophageal dysfunction, you might even experience a delayed gastric emptying. And because everything is moving more slowly, this can also cause reflux. So, if you have a patient that is experiencing symptoms of GERD, what would you consider ordering for your patient or advocating for your patient to get? In order to see what's going on, we want to visualize the esophagus and the stomach because we're looking for signs of inflammation. Or if you have a patient that has symptoms of peptic ulcer disease or gastritis, you also want to look because you might find ulcers. So, in order to do this, we would order an EGD or esophagogastroduodenoscopy. It's easier to say EGD. But basically, this is going to help us to see internally what is going on with the esophagus, the stomach, and if there is inflammations or ulcers to address. We also might want to do a 24-hour pH monitoring, which would help to measure acid reflux episodes within the esophagus. You might also order a barium swallow study to see the structural abnormalities that can occur, like hiatal hernia, or getting manometry diagnostic tests will help to assess the motility of the esophagus and also give you information about the lower esophageal sphincter and how it functions. Overall, the treatment plan is very similar. If it's obesity, weight loss, if they're having trouble laying down and they feel like they're having this regurgitation of stomach acid, you may need to raise the head of the bed. If there are certain foods that trigger their symptoms, we need to reduce spicy foods, alcohol consumptions, or if it was NSAID induced, we need to change to a different type of analgesic. What are the pharmacologic management involved with these type of disease processes? Well, if we prescribe a proton pump inhibitor, it would inhibit the proton pump, which will then again reduce acid production. If we have an H2 receptor antagonist, this also can reduce the acidity within the stomach and the duodenal area. And we'll use this for mild cases, but might have to progress to a PPI eventually. Antacids help with very acute and minor symptoms. And we can also use prokinetics to help increase gastric emptying. Additionally, if it is an H. pylori induced infection, then we are going to have to consider antibiotics. And usually this is the clarithromycin or amoxicillin, which would help to eradicate H. pylori. And most often we're using double antibiotic therapies, 2 antibiotics and a PPI for H. pylori. For some very troublesome H. pylori infections, you might even need a triple antibiotic therapy. So these are just some minor things to consider as we move into the second quiz. And I'll start another video in a minute talking about more of